With manualtherapist.com. So this is a Vidcast Q&A. Someone asked me, why is end range so important? Because you often hear me say, end range is where the magic happens, and I certainly didn't make that up. I got that from one of my favorite McKenzie Diplomat instructors, Dana Green, and I think he maybe even got it from someone else. So end range was originally thought of to reduce a disc derangement, as in a disc protrusion. So regardless of whether you were stretching a dysfunction or what they thought previously was adaptively shortened tissues, or reducing a disc derangement in the cervical, thoracic, or lumbar spine, end range seemed to make more of a difference, and mechanically that was the original explanation. And while there are lumbar studies that support this, if the disc is a mere protrusion and not a herniation, as in the annulus is intact and it's a smaller protrusion, posterior or posterior lateral, it was found in several studies that repeated extension does reduce a disc protrusion. However, often symptoms centralize and lumbar pain abolishes, but the disc actually looks the same, or the MRI looks the same. In the cervical spine, disc herniations are not even that relevant. So studies by Bogduke basically showed that the herniation, the disc is pretty much dried up toward the later 20s, and there's not much of a nucleus left. So what herniates, he doesn't know, and whether or not the herniations are even relevant, he wasn't sure. But still, again, it's been shown that thousands and thousands of McKenzie practitioners, trained practitioners all around the world, because basically McKenzie Institute in every major developed country, that these thousands of trained therapists are finding that end range works better than mid range. So another thing that basically shows that it's not really just reducing a disc is that now that McKenzie concept is applied to extremities, it works for repeated extension for the shoulder, repeated plantar flexion for the ankle seems to improve dorsiflexion, and obviously these areas don't have discs to reduce. So because other studies showed that something like grade 3 ankle mobs helped improve hip strength more than grade 1 ankle mobs, there's something about getting to the end range of a joint. And we know that manipulation seems to be very effective, and that also is just stimulating a joint at end range. And certainly there's speed with manipulation, but the best way for a patient to actually get a similar improvement is to actually get to an end range. And what we think that any mobilization does, which pretty much all an end range loading strategy does, is stimulates joint proprioceptors that kind of bombards the CNS with a novel and non-threatening proprioceptive information. So if the area is on lockdown by the CNS and you make rapid changes, often the rapid changes are not due to capsular deformation, not due to fascial deformation, they're due to a lockdown or an alarm basically going off versus when it was on, the pain threshold was lower and the joint may have been limited in its range of motion. So when you reset the area through either a manual technique or a repeated loading strategy that gets to end range again makes the nervous system think, hey, this joint that I previously thought was endangered is now going through a full motion and it's okay. Nothing hurt. So I think it's okay to raise the pain threshold a little bit, and thus I'm not going to be as vigilant about guarding that area. When the nervous system is less vigilant about that area, you instantly get more motion. You instantly are able to bank more function. Now, are there hard studies on this? It is just mainly theory, but this is based off the theory that, or based off research that shows it doesn't reduce disc protrusions in most cases or in many cases. And end range loading also works for the extremities, and there's no discs there. Also, 3, fascial deformation, capsular deformation doesn't happen, at least quickly. When tissue deformation eventually happens, or when muscle actually lengthens by growing new sarcomeres, that happens like hypertrophy happens. It doesn't happen immediately, and it takes weeks and weeks and weeks. So, frozen shoulders that eventually improve don't fall underneath a rapid responder or derangement category because they actually need true deformation, end range loading is not going to speed that up. End range loading will speed up anyone who's got either motor control stability issue or rapid responder. They're all kind of the same thing to me, because when you rapidly change range of motion, you're really just gaining range of motion that the area had. It's just that the patient didn't know how to access it, or the nervous system was preventing them from accessing it. And that's the best explanation I can give as a Q&A for why end range is important. And again, just trust the thousands of McKenzie practitioners all around the world that have been doing this for decades. End range actually works better than mid ranges in many cases to rapidly improve function, reduce pain, and increase range of motion.